Hello, good morning, good evening, or good afternoon, wherever you are watching this. Um, Today we will be discussing about treatment options. And before we start, we have our disclosures. So, patient and caregiver engagement. This is our initiative by GlomCon for our patients and caregivers. So before we start, only patients and caregivers are allowed to participate in this meeting. This event is not to obtain, solicit, or share medical advice, but serve only for general educational purposes. This event does not and cannot relate to care provided by kidney doctors. And lastly, for individual health or kidney disease related questions, please speak with your doctor. And today we have Dr. Tripti Singh. She is a faculty member of the Division of Nephrology within the Department of Medicine. She is board certified in internal medicine and nephrology and is a member of the American Society of Nephrology and the Renal Physician Association. Dr. Singh is the medical director of the Acute Inpatient Dialysis Unit at the University of Wisconsin and is the director of the Lupus Nephritis Clinic, the only such specialty clinic in the state of Wisconsin and one of the 6 comprehensive clinics in the country. Dr. Singh is highly active in medical education in both classroom and clinical settings and was awarded the 2018 Department of Medicine's Schilling Harkness Teaching Award for teaching excellence in educating residents and fellows. And for that, I hand it over to you, Dr. Singh, to start our discussion and education.
So we're going to talk about treatment options for FSGS and minimal change disease. And most of the things that I'm going to talk about is from this KDIGO clinical practice guidelines. And what this is a organization which is called as Kidney Disease Improving Global Outcomes. It's an organization that gives out guidelines to nephrologists who practice in how to take care of patients, what medicines to use based on the available data from the clinical studies, the expert guidelines that there are. Obviously, these guidelines are more geared towards the nephrologist, so they're obviously very specialized, but my goal today is to make them palatable or something that you as patients can understand and see and know more about them as well. But a lot of the data that I present or the slides would be from this organization, which is for short term called KDIGO. Okay, so we'll start with FSGS. Before we talk about treatment options, we do need to know what FSGS is. So FSGS is a disease where the full form of that is focal segmental glomerulosclerosis. And what that means is that that there is these in our kidney, there are nephrons, which are the working units of our kidney. There are about 1 million in each kidney. That's what we got, which is our kidney here. And as you can see, and we're born in 1 million in each, and every nephron has one glomerulus where the actual filtration of the blood actually happens. So when you get a biopsy of the kidney, this is the glomerulus that we look under the microscope, or the pathologist looks under the microscope. This glomerulus has these blood vessels, which kind of divide into smaller blood vessels where actually the filtration happens. The urine kind of comes, or pre-urine kind of comes out here and then goes into the tubules. As you can see, this looks like a normal glomerulus where these blood vessels are happy. And if these blood vessels kind of shrink and become small, and there becomes a scar in that, which is what we call a scar or sclerosis, that's where the glomerulosclerosis comes up. And then focal segmental means a part of the glomeruli, which is very focal and in a segment of the glomeruli. And that's what the disease is, focal segmental glomerulosclerosis, meaning a scar in a part of the glomerulus. And this is just another cartoon way of looking at it. So this is one of those blood vessels. So we're just looking at a cartoon, and it's under much magnification. So where you saw the blood vessels in the previous one, it's just cut across, and this is the blood vessel. These are the cells outside the ones, which are green cells, and these are the other cells within the glomeruli, and yellow is the cell that surrounds the blood vessel. In somebody who has minimal change or focal segmental glomerulosclerosis, the first thing that happens is the cell on the outside, the green cell, gets damaged. And it is due to this damage to the cell that filtration barrier, or what we call the sieve, where the filtration is actually happening, gets damaged, and then the protein leaks out into the urine. And because this cell is damaged, that causes the leakage of the protein in the urine, and then that's what is the pathognomic of minimal change or FSGS as well. In FSGS, over time, these cells die and then they form a scar, and that's why it becomes a focal segmental glomerulosclerosis. So how do you diagnose it? Or how does the doctor's diagnosis? The first main thing is assessing your kidney function, which is done by a blood test called a serum creatinine or serum cystatin C. And based on those blood tests, your doctor will calculate what we call as the GFR, which is your glomerular filtration rate. It's that creatinine is put into the equation, and a lot of times you'll see in your blood test that's already calculated. And that's one of the things to track when you're looking at your kidney function. The other thing that we want to look at is the protein in the urine, because that's the main thing that's abnormal in somebody who has FSGS or minimal change is that they filter or they lose a lot of protein in the urine. So we check it by a protein, urine protein to creatinine ratio. So your doctor might take a urine sample, and which would be a spot urine that you just pee in a cup and check the protein and creatinine, and they do a ratio of it. Or you might have to collect all that urine for 24 hours in the jug and give it to the lab after collecting all the urine for 24 hours. And the goal is to look at how much of protein is in the urine. Normally, there should be no to minimal protein in the urine, and somebody who has FSGS or minimal change tend to have a lot of protein in the urine. But those are only just indicators. For somebody to diagnose minimal change in FSGS, you do need that kidney biopsy to actually look at those glomeruli, the ones that we talked a little while ago, under the microscope. So you need to look at those glomeruli under the microscope, and the pathologist who reads that looks at those cells and see if those cells are damaged, if there is scarring in the kidney, and that's how they kind of diagnose the disease. Sometimes your doctor might repeat the biopsy. It sometimes helps in if you're having a flare of the disease again, or to tell you what to expect in the future, what we call as estimation of the prognosis of the disease as well. So now, now that we have the diagnosis, we know how what tests to do. Let's come to how do we manage these diseases. So both minimal change and FSGS. I'll start with what we call as general treatment guidelines, meaning something that should be done in both the diseases or any disease, kidney disease, where you have protein in the urine, or what we call as proteinuria. The two things that happens because of protein in the urine or proteinuria is you get edema, which is swelling in the legs, and sometimes swelling in your belly, sometimes swelling on your face as well as it can lead to higher blood pressure as well. So both of things that happen. Obviously, if proteinuria continues, it can cause damage to your kidneys as well over time and lead to that elevation of your serum creatinine also. So the things that help decrease proteinuria is limiting your sodium in the diet, or salt, which is the mainstay in helping decreasing the protein in the urine. Is sodium restriction, and we really want to decrease that sodium or the salt to less than 2 grams in 24 hours to help decrease that protein in the urine. Sometimes your doctor might ask you to decrease the protein a little bit in your diet as well. That decreasing the protein in the diet will not help prevent protein loss in the urine, but it helps the kidney sometimes in decreasing the toxins that it has to get rid of. But if your protein in your blood is less, then sometimes it's recommended to increase the protein in your diet. So it has to be a balance, which sometimes you might have to see a dietitian and a nutritionist to get a good diet regimen, depending on your kidney disease and your blood test that there is. And then increase physical activity. Smoking cessation. So if you're smoking, it's really recommended to stop smoking because smoking leads to progression of kidney disease much faster, and reducing the alcohol consumption. Then the next thing is coming to the medications. So some of the medications the way that we divide is some of the medications that decrease protein in the urine, and the other type of medications that are immunosuppressant or suppress your immune system. And I'll come to both of them in the next couple of slides. So we kind of talk about lifestyle modifications already, which is limiting the sodium, increasing your physical activity, stop smoking if you smoke, and reducing your alcohol consumption. If you do have swelling, that restricting your sodium or salt in your diet would help with the swelling. And sometimes your doctors might use water, what we call as water pills or diuretics, the most common being furosemide or Lasix. If you're on that, your doctor might want to check your blood work frequently to check some of the electrolytes in your blood, as well as creatinine, which is your kidney function as well, by the blood test. And then how can we decrease that protein in the urine? So again, I think the same, I can't reinforce how much low salt intake it helps in decreasing the protein and keeps your kidney working, is that decreasing that salt to about 2 grams. Having a good blood pressure control, and we really want your blood pressure to be low, below 120/80. The lower the blood pressure, the less the protein in the urine. And the most common medication that we use to decrease the blood pressure is what we call as ACE inhibitor, which is or angiotensin receptor blocker, the most commonly that are used in the United States. The name of those are lisinopril or losartan. There are a lot of different names of the medications in these umbrella of medications of what we call as ACE inhibitors or ARBs. And they help both decrease the blood pressure as well as help decrease the protein in the urine. Then there's a newer class of medications that help decrease protein in the urine, what we call as, for short form, SGLT2 inhibitors. They're called as sodium glucose transporter 2 inhibitor, the most common that are available in the United States. The name are dapagliflozin or empagliflozin. Again, those are the chemical names. When you talk about the trade names, most commonly are Farxiga or Jardiance. Those are the 2 most common medications in this group, and they also help decrease protein in the urine. And the third medication that helps decrease protein in the urine is something called spironolactone, which is also a weaker water pill. And then we talked about smoking cessation, and if you are overweight or obese, and losing weight to ideal body weight also helps decrease protein in the urine. So these are what we call as general treatment guidelines. We haven't gotten into what we call as immunosuppressive medications, but these are really important as well in decreasing the proteinuria and keeping your kidneys working if you have FSGS or minimal change disease. Then there are some other complications that can happen due to protein in the urine, that it can lead to high cholesterol levels. So your doctor would check your cholesterol level and consider starting a medication to decrease the cholesterol levels in your blood, which commonly is called as statins. It could be any of the statins. Then one of the others, sometimes when you have a lot of protein in the urine and you're having a flare of FSGS, you have an increased risk of having blood clots. And your doctor sometimes could consider, especially if you develop a blood clot, to be on a blood thinner when you're having this large amount of proteins in the urine. And then because you lose these proteins, you also lose a lot of antibodies, which are the proteins, which are different types of proteins that help us fight infections. And so it is recommended for people who are having a flare to have vaccines, appropriate vaccines, which would be a pneumococcal vaccine to prevent pneumonia, to get a flu vaccine annually, and to get screening for tuberculosis, hepatitis B, hepatitis C, and HIV, if it is suggested appropriately from your clinical status. Now let's come specifically to minimal change disease to start with, and then I'll go to FSGS after that. So now I'm going to talk, so the ones that we talked apply for both of them. And now I'm going to just talk a little bit more about minimal change disease. And here we're going to focus more on medications that help suppress your immune system, because both of these are thought to be autoimmune diseases, meaning there's something wrong with the immune system that's attacking the kidneys and attacking those cells that we talked about that affect the barrier or the filtration barrier and causes the leakage of the protein in the urine. So for minimal change disease, obviously, like I said, the only way to diagnose it with a kidney biopsy. And people who have minimal change disease actually have very good long-term survival of the kidney, meaning that the kidney keeps continuing to get to work really well if they respond to a group of medications which are called as glucocorticoids, or something called prednisone. And that would be the first medication that your doctor might use, or your kidney doctor might use to help you treat, is prednisone or glucocorticoids. And so if you do have, and if you don't have any contraindication to those, which is you're not have bad diabetes or any psychiatric illness, then the first thing would be glucocorticoids, which are usually continued for about 16 weeks. For 2 weeks, you're going to be on high dose, and then they're going to check your serial urine protein, and if it's coming down, once it's completely gone, then they might start tapering it and continue it for 2 weeks after you're in complete remission and there's no protein in the urine. However, if somebody cannot take prednisone because of their other comorbidities or other diseases that they have, or they've taken it before and it did not work for them, or if they had a lot of side effects from them, then the medication, the first line of medication, is what we call as calcineurin inhibitors. Again, it's a fancy name of a combination of medications, which is either called tacrolimus or cyclosporin. So those are the two common medications that we use, which are the first line, which is tacrolimus or cyclosporin, if somebody cannot take glucocorticoids or prednisone. However, if somebody responds to steroids, they do steroids, but as soon as you decrease the dose of the steroid, that protein in the urine comes back. This is what we call as relapsing or steroid dependent, meaning as soon as you're dependent on the steroids, and once you take the steroids away, the protein in the urine comes back. That's when we think about a resistant disease, and that somebody would start either calcineurin inhibitors, which would be a pill twice a day, which would be tacrolimus or cyclosporin, as I said, or it could be an infusion medication, which is done every 6 months, the most commonly being something called rituximab or cyclophosphamide. Those are both medications to kind of kill your immune cells in your body, and those are infusions that you have to go to an infusion center, get an IV, and get the infusion as well. And the goal there would be to get you off the steroids or the prednisone at that time, because you become dependent on prednisone, which has a lot of side effects as well. So this is about minimal change disease. Now come to FSGS. So we've talked about the diagnosis of minimal change happens by the biopsy. So is the diagnosis of FSGS by the biopsy. And when you look at the biopsy, this is how it looks under the microscope. And this is what your pathologist or the pathologist or your kidney doctor is going to look under the microscope. And this is one of those glomerulars that we were talking about. We all have about 1 million of each in our own kidney. And these are those tiny blood vessels in our kidney. This probably image is about 100 times the magnification. So these are very tiny, and you cannot probably see it by naked eye, but this is 100 times magnification. So when you look under the microscope, this is how it looks. And these are these tiny blood vessels. And in this area, in the top 12 o'clock, you can see these blood vessels are gone, and this is kind of the scar that we look. And because it's in the segment of a glomerulus, meaning a part of the glomerulus, it's called as focal segmental glomerulosclerosis. And that's how this person who had this biopsy was probably diagnosed with FSGS. And so if you're on your kidney biopsy, if you do have FSGS, then your kidney doctor is going to kind of look at two different ways. If you do have a lot of protein in the urine, which is when you look at the protein in the urine and it's large amount, and that's the number that the kidney doctor is going to look at, it's about 3.5 grams per day in a 24-hour, or 3.5 when you do the ratio of urine protein to creatinine. If it's more than that, as well as your protein level in the blood is low, and that's one of the key things in people with FSGS. If your protein levels in the blood starts going low, then it's something what we call as nephrotic syndrome. Again, nephrotic syndrome is just a syndrome which can happen both in FSGS and minimal change, or in any other kidney disease where you're losing a lot of protein in the urine. So if your protein levels are low, you get swelling in the legs and you have a lot of protein in the urine. That's what we call as primary FSGS. And that's where we would treat with immunosuppressive medications, compared to somebody who does not have a lot of protein in the urine, or if they have a lot of protein in the urine, but their protein level in the blood is normal, then we call it something called a secondary FSGS, or we would really want to rule out secondary FSGS. Secondary meaning it's not primary disease in the kidney, but something else in your body that's causing the kidney disease. And we don't know what that is. It could be a lot of things. It could be an infection, and that's what my next slide is. It could be an infection. It could be some of the medications that you had been on before. It could be because you had a previous surgery to the kidney. It could be because you were born preterm. It could be because you have any other kidney disease. So there could be a lot of factors. Like it could be secondary FSGS. And if it is secondary, then usually we would not consider giving you steroids or prednisone or any of the immunosuppressive medications. But if you do have primary FSGS, which is when you have a lot of protein in the urine, you have swelling in the legs, and your protein levels in the blood are low, that's when we think about considering immunosuppressive medications or the steroids, and I'll come to that in a minute. But I want to take a little bit of a segue here to talking about what we call as genetic forms of FSGS. So there's some types of FSGS where there could be a genetic mutation that might be causing FSGS. And for the guidelines, it's recommended to do a genetic test if you're not responding to the first line of treatment. Or if you have a family history, meaning if somebody in your family has FSGS, then it is recommended that that the person would be tested for genetics, any genetic mutation that's known to cause FSGS, or if your doctor gave you steroids and that's not helping with decreasing the protein in the urine, that's when we would recommend a genetic test as well. So how do you treat FSGS? It's kind of same as the minimal change disease, like we said. It is somebody treating with prednisone. So this is how I would put it as. So you start with high-dose prednisone, which is your corticosteroids, usually about 1 milligram per kilogram, and then you kind of divide it into three different ways, depending on how somebody would respond to steroids. So you are either steroid responsive, meaning you took the high-dose steroids for about 2 to 3 months, you start decrease, the protein in the urine slowly starts going down, and you what we call is steroid responsive. This would be the best scenario here. And somebody who's steroid responsive has the best outcomes in their kidney function over time. There are some people where what we call a steroid dependent, meaning you got diagnosed, your doctor started you on high-dose steroids, your protein came down, and then they started decreasing the steroids slowly. And as they started decreasing the steroids, the protein in the urine goes back up again. And that's what we call a steroid dependent, meaning you're dependent on the steroids to keep the protein in the urine down, compared to somebody who got started in the steroids and never had decrease in the protein in the urine with the steroids, and that's what we call as steroid resistant. Both of these should have been on steroids for at least 16 weeks or 4 months before being labeled what we call a steroid dependent and steroid resistant. And if you do have steroid dependent and steroid resistant, then the guidelines recommend to consider starting tacrolimus or cyclosporin to be able to get you off the steroids, because steroids for long term have a lot of side effects. So that's kind of what I would say. The major treatments for FSGS. Obviously, if you do not respond to tacrolimus and cyclosporin, then we are going into every person, looking at each person more individualized as to what other medications can be used, but because there's not much data beyond that in bigger studies. And then the guidelines recommend either you can do the infusion medicine or to consider enrollment in a clinical trial to find a newer medication that could work, which is being studied in one of the studies. Here I would take the segue of introducing our webpage as well, which is what we call as the GlomCon page, and it has a lot of literature and a lot of handouts which you can kind of look over, detailing about different kidney diseases and different glomerular diseases, which you can kind of read at your own pace and get to learn more about it. And there's also a list of clinical trials which are currently enrolling on the website as well. where you can look into more by the disease type. If you go into FSGS, it will give you a list of the clinical trials that are enrolling, as well as for minimal change, as you can see if you click on it, all the clinical trials. One of the other ways to look at the clinical trials is the NIH website as well. They have a website called clinicaltrials.gov. And there you can put in the condition of the disease that there is, and you can put in your location, and you can see all the studies that are currently recruiting or not yet recruiting as well. So let's say this was what I did. I put in FSGS, and as you can see, I had 107 studies that came up if you just do FSGS. And then you can put in filters depending on which are currently recruiting or which are close to your location, and then a whole list of them come up as well. Depending on the filters. So if you put the filter of currently recruiting, then it goes down to somewhere about 28, as you can see here. And then 46 are completed, and they're probably following as well. So the major take-home points I would say is that you do need a kidney biopsy to diagnose minimal change disease or FSGS, and that's the only way to diagnose the disease before the treatment is started. But for both minimal change or FSGS, steroids or prednisone remain the mainstay of the treatment. But non-immunosuppressive treatment like good blood pressure control, low salt diet, smoking cessation, losing weight are very important as well to keep your kidneys healthy and working. If you have any questions, this is my email. Feel free to email me for any questions, or we do have on that GlomCon page, the page, place where you can put your questions, and we can get to those questions on the next webinar that we have, which we usually have on second Sunday, and the timings are on the web page as well. Thank you.